So we had a really incredible morning, and we now have heard all these great stories. There'll still be more. But at this point, what do we do next? How do we take all this and lead it to change within the system? So this next panel is going to explore the real systems change and what it can look like from South LA all the way to the State House, and how storytelling, survivor leadership, and healthcare systems, community partnerships can work together to build something better. Can't think of a better person than to guide this conversation than Gabrielle Brown, Director of Maternal and Infant Health Initiatives at Black Women for Wellness, founding partner at CPWA, and a powerful advocate for birth justice and community systems change. Please join me in welcoming Gabrielle Brown.
Okay. Thank you all again for being here and for holding space with us throughout today's conversation. We've heard very powerful stories of survival, advocacy, frustration, resilience, and love. And while each story is deeply personal, together they reveal something much larger about the systems families are navigating every day. This next conversation is an opportunity for us to move from story to systems, because this is not only about raising awareness, it's about understanding what families actually experience in real life, where the breakdowns occur, why people continue falling through the cracks, and what it will take for us to build something better together. What we know is this: not one single person, organization, or institution can solve these challenges alone. Real change requires coordination across community spaces, clinical systems, public health infrastructure, policy leadership, and lived experience. It requires us to stop working in silos and start building systems that are responsive, connected, culturally grounded, and accountable to the people they are meant to serve. So today's panel will help us explore two critical questions. What are these stories revealing about the failures within our system? And equally important, what can we begin building right now? Before we begin, I'd love to invite each of our panelists to briefly introduce themselves, their name, role, and connection to this work or lived experience. So I would love to start with you, Cassie.
Already. I'm Cassie Gardner-Manchikian, founding director of CPWA.
I am Kimberly Gray. I'm the director of Perinatal Mental Health Equity with Maternal Mental Health Now. I come to this space through my own lived experience through pregnancy loss, with a particular interest on supporting Black families and Black perinatal providers, continuing to uplift this work through the voice of community.
Hi everyone, my name is Dr. Rohit Pasi. I'm the Chief of Neonatal Perinatal Medicine for Kaiser Permanente South Bay Medical Center, and I'm also the physician leader for Equity, Inclusion, and Diversity for Kaiser Permanente. I must say that I come here with, this is my second time coming, and I come here with many intersectionalities of my life, not just as a physician leader, as a neonatologist, but also as an immigrant, also as a father, also as a husband. And I must say that whatever I discuss today and explain is based on my own learnings as a physician and do not represent official statements of Kaiser Permanente. Thank you.
Hi, everyone. We're going to keep you awake after that lunch, I promise. I'm so excited. It's so lovely to see you all again. I am Elise Springer. I am a licensed marriage and family therapist, founding board member for PSI California, and serve as the current co-chair for Policy and Advocacy Committee. And I will pass it back down to Cassie.
Thank you. You all are so amazing. And so, as we move into the discussion, I really want to ground us in the reality that families are often navigating fragmented systems during some of the most vulnerable moments of their lives. And while the stories may sound a bit different, many point back to the same recurring challenges. On the screen, you'll see several themes that consistently emerge: screening gaps, referral breakdowns, lack of coordination, cultural disconnect, fear and stigma, fragmented systems of care. These are not isolated issues, they are patterns. And so I'd like us to explore not only what's happening, but why. And so Cassie, I'd love to start with you. Through the stories that the California Perinatal Wellness Alliance has collected across the state, what patterns are emerging about where families are most often falling through the cracks?
Thanks, Gabrielle. So we've talked about it a few times today, but this is our statewide storybook of 50 stories from throughout California. And we actually collected 50 more registrations, stories, even just from today's event. So thank you all for submitting your stories. While every family's experience is unique, there's many patterns that are emerging around awareness, alignment, and action. So first, awareness. Many families and even providers don't even recognize the signs of perinatal mental health challenges very often, or don't feel safe asking for help. Second, alignment. When families do seek help, they often fall through the cracks of a fragmented system. And third, action. These challenges are absolutely preventable and treatable when community connection and coordinated support exist. So first, awareness. Many parents don't even recognize they're experiencing a perinatal mental health issue. They might thinking, I'm failing, or this is just new motherhood, or I should be able to handle this. And many providers miss the symptoms too, especially prenatal or OCD or anxiety, psychosis, or even paternal mental health. And the biggest barrier is getting help is stigma, but underneath the stigma is fear. And as we heard from Monet's story, many families, especially Black, immigrant, LGBTQ, and historically marginalized, are understandably afraid of what may happen if they disclose that their babies might be taken away. And as Supervisor Horvath said earlier, we have created systems that often prioritize reporting over supporting. And people can't advocate for care that they don't even know should exist, right? So that's why I often say perinatal mental health is a preventable public health crisis that's hiding in plain sight. Thank you. The second pattern is really around alignment or fragmentation. The 20-month period from conception to 1 year postpartum is really an intersection of racism, sexism, a fragmented healthcare system, the lack of integration between behavioral and physical health, economic stress. And so it's no wonder, because it's like families are being set up to fail. We're expected to navigate OB care, pediatrics, behavioral health, hospitals. And when families fall through the cracks, most consistently is along that care pathway from screening to diagnosis to treatment and referrals and the follow-up, because screening alone doesn't equal treatment. And so across our stories, we hear about long wait lists, lack of trained providers, limited health insurance coverage, and systems that unintentionally deepen trauma. So even for my story, it's a postpartum psychosis story, and we hear from 6 psychosis stories in here. One is who's here, flew all the way from Sacramento. Thank you, Millie. Many people found that hospitals actually make things worse and actually give you even more trauma, including psychiatric units separating mothers from newborns. So families are essentially being set up to fail. And the third pattern across the stories is hopeful, and that's action. That's why we're all here today. Again and again, we see that change becomes possible when people feel seen, supported, validated, and empowered with agency to act. And that's through groups like the Mother Board, through doulas, Black birth workers, support groups, culturally rooted spaces. And families repeatedly told us that what helped me most was finally feeling less alone. So the good news is we know a lot about what works, and this is not a lack of solutions problem. It's really about again, awareness, alignment, and action.
Wow, thank you, Cassie. I really appreciate you grounding us in the compounding of challenges patients face parents face during their perinatal journey, as well as statewide patterns and the human impact behind the data. And so next I'd like to move to Dr. Pasi. From a provider perspective, where do breakdowns most often happen between screening, referral, and actually getting families connected to care?
Thank you. I believe the breakdowns really happen because the system has been built in a typical way. System has been built to take care and adopt a cookie cutter approach, to adopt a one size fits all approach. Many times systems are built to check some boxes, while we forget that there are human beings at the other side of it. Not just human beings, but diverse human beings with many multiple stories, and you just cannot have one size fits all approach. One of my favorite things I talk about is there is no quality without equity. We often focus on quality of care. There are Joint Commission, there are regulatory requirements for quality, but there is really no quality without equity. It's not a system. It's not a system if it doesn't work for everybody. And there's a lot of work that goes into that. Sometimes doing the right thing is often the difficult thing to do. And we often, for multiple reasons, adopt a simplistic approach to these things, and what that leads to is inequity. We have often treated these conversations and taking an individualistic approach, as a cherry on top of ice cream. It's not a cherry on top of the ice cream, it is the whole ice cream. The flavor just doesn't work without it. So having that right from the beginning in the systems, incorporating it in medical education, incorporating it in the bottom-up approach is key. And our whole system has based on the backs of these inequities. Last year when I came, I talked about the story of Lucy, Betsy, and Anarka, who were three enslaved women on the backs of whom the surgeries and gynecological surgery was perfected. But we don't talk or teach about these things in medical curriculum. And we are kind of incentivized to take a one-size-fits-all approach. But we really need to break that. I think that's one of the main causes for where breakdowns happen. Childbirth, being a parent, is a highly stressful time. And from a personal example, when I'm in the NICU, and now on top of that, baby is now admitted to the ICU, not just something parents expected. So now the trauma and the difficulties are multifold. And our systems are based on that acute care. You're looking at just the baby, what's happening, while negating the impact it's having on the birthing parents. So opening our eyes, taking the difficult path, but the right path, normalizing these conversations, normalizing the role of equity, and really, again, hammering on that fact that there is no quality of care without taking an equitable approach. It's not a system if it works for very few people. It doesn't work for everybody, especially the most disenfranchised. Being an immigrant myself, one other common theme I see is how different communities and immigrants also look at mental health. In my culture, stoicism is promoted. There was, I think, a study done where people were reporting low pain scales just to seem more stoic. And now, if you don't understand those backgrounds, if you don't take that extra step, you don't go a step beyond the regular checks and balances, you are going to miss these patients. So it's our duty to create those systems, to make these conversations more accessible, to make mental health care more accessible, right from the beginning, I would say even by the time you show up in an OB office talking about it's too late. It's going to go even before that even when somebody is of childbearing age or planning to have a baby, these conversations need to become a forefront. We need to come to the patient rather than expecting folks to navigate those difficult systems. And until we go there, it's going to be difficult.
Thank you, Dr. Pasi. And you're right, our experiences are not one size fits all, and thank you so much for naming that. I think what's especially important in what you said is that it's important to recognize the role of equity within delivery of care and challenging the norm. within the health system. Kim, bringing this conversation closer to home here in LA, where are families most often falling through the cracks locally, and what's missing between hospitals, providers, and community-based support systems?
Yeah, I think when we start to think about this, we have to look at the fact that we have community, cracks, care. So there's this pathway in terms of how we need to get to the care that's needed. And the reality is that oftentimes the system assumes access. Dr. Posse touched on this a little bit. You assume that someone is going to walk into your space, they're going to divulge all of their feelings out to you, and then boom, there's a treatment plan and care can happen. The reality is that when you're not taking into consideration the barriers of actually getting someone in the space, when we're talking about communities of color, under-resourced spaces, indigenous communities who are oftentimes very widely separated from the systems of care, and then you're thinking about what we're dealing with right now in this climate in terms of our immigrant population, there's already a distrust in the system that exists. So each one of those cracks becomes wider and wider and wider. So now you're not just looking at cracks, you're looking at gaps in the entire system. So how do we start to think about what do we do to make sure we're closing that as much as possible? And the reality is that there are community members who are already doing this work, who are already holding up that space. Many of you are actually in this room. We have birth workers, we have physicians, we have folks like Dr. Posse who are really taking into consideration what does equitable care look like. So we have to continue to bring alongside that system and really trying to not only put out what's there, but also listen. Understand what we can learn from our lived experiences. Each of us have shared many stories in this space. You see folks in this room who you work together either day to day, or how many people met a new person today in this space? Absolutely. That's beautiful to hear. And so the solutions exist within the spaces that we're in right now in our community. The problem is making that connection so the systems of care are actually soliciting, but also listening when it's said. I think the reality of saying you know what you know and you know what you don't know is very important. People are afraid to really recognize and acknowledge what they don't know. And our systems of care, particularly hospital systems, providers in the spaces, there's so much knowledge and information that they hold that they operate within that, but they're not willing to say what's missing, and they're not willing to learn about what is actually needed to make sure our care systems are actually held up. So we know that there is system dismantling that needs to happen. The reality is that we need care and we need help now, today. So we have to start thinking about, while we're addressing the dismantling of these systems that haven't served us for some time, how are we instead bridging over those cracks? How are we building out partnerships between hospital providers and communities and really working to understand how we can collaborate and work in a collective way?
Thank you, Kim. I appreciate you naming the importance of that community infrastructure piece and having those relationships with birth workers, advocates, allied clinicians that are on the grounds doing the work and not necessarily just focusing on services. Elise, California has made major progress around screening for perinatal mental health challenges, but where are families still struggling to access meaningful treatment and ongoing support once those challenges are identified?
Thank you so much. So, oh my gosh, so I know I only have a time limit, but I could take up your whole afternoon. But I'm going to tell a little bit of a story shared with permission. This is a client, a male client, and I just want to acknowledge that a lot of times we only focus on birthing person and baby, and we miss whoever the partner or dad might be. And of course, what that means is that we're only treating two legs of a stool. So if you've heard me talk before, you've heard that rant, I have to say it. It wouldn't be fair to me to sit up here and not say that otherwise. But this is a story of a dad who actually had a stillbirth. And the hospital social worker was incredibly empathetic, but did no screening of the family, right? Because we know right now we have two ABs that focus on screening in California. One of them, AB 1936, focused on screening during pregnancy and postpartum. And a lot of times the way hospitals are doing this is that they screen at discharge, right? But because this was a stillbirth, neither parent got screened, with the assumption, of course, from the hospital social worker that they were likely going to have some trauma. And you would think that there would be a warm handoff to some clinical services and support, and there was not. And while a lot of times we know in stillbirth, for example, or just infant loss in general, the whole sort of continuum, what ends up happening in a cishet couple is that mom is really struggling, she's having her own experience, and dad is the person kind of forward facing. And what ended up happening was he ended up basically having kind of a break because there was so much stress and pressure and no support, because even when mom did eventually get linked to services at a follow-up checkup with the OB, which doesn't always happen because many of you have had that experience where it doesn't happen, he did not get that connection or that warm handoff. And that is a real issue that is happening. If you can find your way to clinicians who even know that perinatal mental health exists, we all do in this room, but that is not the norm. We only have 1,450 PMHCs in the whole state. California is huge. We have 400,000 births every calendar year. That is an enormous amount of births. That's usually a couple of parents, maybe some aunties, grandmas, and cousins who are also doing some childcare, right? So one of the biggest barriers in the ways that people are falling out of care is that they don't know that perinatal mental health exists. And not just that, that's at kind of highest levels. Cassie and I have been doing a lot of work. CPWA hosted a really wonderful roundtable last month, and the amount of folks in that room who are sort of higher level stakeholders that did not know that clinicians are not trained in grad school or after getting licensed was pretty mind-blowing. Like, the whole systems of care don't know that it's not a requirement in the state. And if you heard me talk last year, you knew I was continuing to fight to kind of make that happen, and I'll update on that in a little bit. But a big factor is that the folks who are making these decisions to try to operationalize care, people who genuinely care about trying to make a difference here, they just don't know that the system is broken upstream. And there's been so many downstream approaches, like trying to regulate screening or how many times there is screening. So a hospital social worker could just rotate in on their first day on a unit and have zero training in perinatal mental health. Truly, that is possible. A Medi-Cal clinic worker at an FQHC at a federally qualified healthcare, or just a DMH in LA County, could walk in, be servicing folks with brand new babies and have zero training in perinatal mental health. And that is a big place where the breakdown happens.
Thank you, Elise, for naming these realities so clearly. And while these challenges are significant, I also want us to spend time imagining what's possible, because families deserve systems that are coordinated, compassionate, and built to actually support healing and care. And so despite the fragmentation we've discussed, there are also promising models, partnerships, and policy efforts already emerging across California. On the slide, you'll see several areas where opportunities for transformation already exist, including care coordination, provider support, community partnerships, accountability, systems alignment, leveraging technology, and innovation. So let's talk about what building better systems could actually look like in practice. And so Dr. Posse, what would stronger, more connected systems of care actually look like on the ground? And what would help providers better support families before they reach a crisis point?
Thank you. I will tie in the answer from the last discussion I was doing. I think we need to take that knowledge that it is not a one-size-fits-all approach. Take that knowledge that we live in a community. Los Angeles is a very, very diverse place. And how do we transform that knowledge into equitable systems? And one thing I'll add here is, when we talk about diversity of our patients and equity, one of the things that's often forgotten is the conversation around neurodiversity. We often take into ratio ethnic diversity, language spoken, other things into account. But we often end up assuming that people process information the same way. So I just want to put in a plug there for neuro-inclusive care as well. It has a personal meaning to me as a parent of a neurodiverse autistic child, and Many times when we see the struggles of ourselves in his care, despite being a physician, despite knowing the system, I often wonder if we have to go through this. I mean, I can't even imagine that families who don't speak English, family that might not have the resources, have to go through. This has led us to ignite that conversation in my own practice. We hosted a podcast last month within Kaiser Permanente on what neurodiverse care looks like in the medical setting. And I hope we will incorporate that in in mental health as well. Because I think it ties in significantly. We have to assume that people don't think the same way. How do we look at that equitable? How do we make accommodations? To real substance of what is being done and what can be done in building an equitable system or a better system, I would bring in something controversial here, which is AI and artificial intelligence. You know, people are talking a lot about AI. There are a lot of hesitancies around it, but I think AI might have great use in this arena. AI can do a great job in really finding the missing plugs, finding the missing information. Many times the care is received at different places in different functions. AI can really be a resource for clinicians in compiling that information. Because, you know, the truth of life is that, I'll speak from a physician perspective. When you go into that clinic, when you are seeing your OB or seeing your provider, I mean, they are given 15 to 20 minutes, right, for that clinical appointment. And they want to do more, but their hands are tied at times. So how do we leverage AI? How do we leverage technology in helping clinicians as well as patients in kind of creating that information? A simple example could be flagging charts, right? AI could look at previous hospitalizations, previous birth history, place of residence. We know that certain zip codes. We have something called as California Healthy Places Index. I don't know if anybody has heard of that. It really looks at the disease burden. So that could flag the zip code. You know, if somebody is from a background with that zip code, they are at a high risk for needing those resources. Maybe they need more time with the clinician as well. Other thing, I've personally used AI for my own son because we struggle. We're struggling with the school department, with the school district, with our own healthcare at times. What I've asked AI is to compile the resources and to really look over the blind spots of ourselves. You know, we are looking for a placement, for example, and we have found immense use of AI in that arena, into thinking things we weren't thinking. So I think that can be a great resource, and leveraging technology. It is here to stay. It's not going away, AI. So how do we make it work for us? How do we make it work for systems? This can be something very concrete and actionable, which can really help transform and really help the clinicians to identify and provide resources to the patients.
Thank you for that. I know that AI is controversial, but I think that if it can improve the outcomes of parents across California, it's something to look into. And so, Elise, what would it take to build a stronger perinatal mental health workforce in California?
Oh, I have been waiting my whole life to answer this question. Well, look, a couple of things. I mean, I mentioned before, one of the things we've been doing is trying to get the licensing boards to have some requirements for perinatal mental health, right? And because the only thing that is currently in California, it is all regulated in our legislature, what goes into learning in grad school and postpartum. So a lot of the work that we've been doing over the last couple of years has been, hey, boards, before you license someone, or even in graduate school, people should probably be taught not just about human sexuality and child development, but that whole biopsychosocial span between the two. So where we are with that right now is the Board of Behavioral Sciences agreed a couple of weeks ago that they will send around a bulletin. So I'm just going to say that again. Their answer at the moment is to send around a bulletin. So as you can imagine, that is not much more than a Band-Aid. However, it's something. It's a step forward. I think my fantasy of this is that we have an Office of Perinatal Mental Health, right? And we have something called the Office of AIDS in California, and it works in the biopsychosocial realm. An Office of Perinatal Mental Health would have very similar departments, where it had a Department of Behavioral Intervention, which sort of focused not just on all the Medi-Cal managed plans, but also focused on sort of that case management, the psychiatry hotlines, that linkage to therapists. There would be screening, prevention, and treatment, right, which is sort of a little bit more self-explanatory. You know, in HIV and AIDS and under the Office of AIDS, there's something called ADAP, right, which is a sort of assistance program for folks who are not able or don't kind of either meet Medi-Cal or so on, who really need that extra support. And under that, we could have a perinatal, Department of Assistance, right, where it's like short-term care, linkage to kind of intermediate coverage. That's where maybe we could house that inpatient programs and those outside. The inpatient and the outpatient programs. So that Office of Perinatal Mental Health under the CDPH is my fantasy, and it's been my fantasy for about 15 years. So whenever someone asks me, like, what can we do? I'm just going to say that answer. I don't know magically how we'd ever get the money, let alone the money during this administration. But I think it would be the most practical way to kind of sort out what California's already doing, because California is trying to operationalize this. Like, there are those folks who were in that room a couple of weeks ago who understand this is a real issue, and all the data shows it. I will say we actually don't track anything about dads. So if you ever hear about maternal morbidity in the state of California in terms of suicide being leading cause, we actually have no idea about that with dads. We do not track it. The coroner's office does not even check a box if a dad dies by suicide. So again, this is something that really does need to shift in general if we're going to do the whole part of the stool to help all families be well in this space. But again, my real answer, and I just talk really fast, right? So I think I have a couple of 30 seconds, but I'm going to give it up to a co-presenter here and just say, you'll just take away the full stool, all three legs, right? All the parents, and Office of Perinatal Mental Health. Those are our big takeaways.
An Office of Perinatal Mental Health, that sounds like an amazing idea to me. I don't know about y'all. And ultimately, development of the perinatal mental health workforce is such a critical part of this conversation because systems can only function well when people are properly supported and well equipped. And so I'd like to move to Kim. What does meaningful coordination between hospitals, providers, birth workers, and community organizations actually look like? And where are you already seeing promising models emerge locally?
Oh, that's a big question on the actually look like. I think there are lots of folks in this room who would have insight in terms of how we can work together to collaborate in that way. But what I do think by sharing some of the models that are currently working, it gives us some idea of where are the spaces that we can start to think about really implementing practice change, and then how can we scale that. I think it's one of the biggest things that we have to take into consideration right now for ourselves is like, where are the bright spots? Where are things actually happening? Where is there joy in this space and in this work? Because it can be very daunting to try to tackle all of these things at one time. But through some of our community models, we're really seeing some really effective change in the space. Some of those individuals are in this room, so I'll just name a couple of things that are happening at various levels. So peer support. If you are familiar with peer support or community health workers or promotoras in the space, so really having community-based health workers who are able to support and help navigate, particularly with families. Dr. Terry talked about this earlier, just in terms of the needs of knowing that community is oftentimes the first point of contact. Your family is often the one who sees that there's a change or a shift. So it's good to have individuals who are in the community actually interacting with families so that they can be better informed and they can have someone to help them support through navigating resources. So when hospital providers, clinics, and institutions really partner with those individuals, it creates a space for the things that we see happening within the homes, like home visitation, to actually be uplifted so we can understand what are some of the barriers and make sure that those resources are actually brought into the community. Then to Elisa's point around training Training is so critically important, not only for our licensed clinicians, but also for those who may be the first point of contact. There are training opportunities for families to be educated on how to identify, how to make sure you know where to walk with someone to actually be able to receive care. But then also our doulas, our midwives, our lactation consultants, the folks that are actually interacting with individuals on a very regular basis. How are you able to actually see and identify when a perinatal mental health condition is actually being presented? So creating those small windows of opportunities and training now helps us build towards these broader systems of mandated trainings for our physician and our providers in care. Then, of course, there is also the space of the lived experience. So I'd like to highlight and give a shout out to the motherboard, members of the motherboard who are sitting over here, who are shaping not only their lived experience as parents walking through, but they bring such a wealth of knowledge and expertise in the space, because you have to remember we're whole human beings. So we're parents, we're mothers, we're fathers, we're birthing people, but we also come with all of these beautiful skill sets that can be used to advocate both locally and at the state level. So having the motherboard, who is an organization of mothers who have lived experience, advocating for the community, bringing and elevating the lived experience up, and those are the individuals that we need to be talking to, those who are in close proximity to the situation, actually having conversation and saying what will work for you, what are the needs that are there. So those levels of partnerships between providers and hospital institutions is where care really starts to shift. So just having this particular place where we're thinking about how do we collaborate more concretely in this way. One of the things that I'm very excited about, because I get very excited about solutions, and I get very excited about small milestones too, because we can't forget those. If you think about our children growing up, we get excited when they do anything. We are snapping pictures, and we know that they're achieving these big steps, but these small milestones really matter. And so does the small incremental work that we're doing. It really matters. Maternal Mental Health Now is partnering with an organization called NICHQ at the national level, really starting to look at how do we reduce infant and maternal mortality, and how do we think about that, because we know that perinatal mental health is one of the leading complications. So how are we working in tandem to create solutions and change there? So we are serving as an anchor organization, working with community-based organizations within our local community to identify how can we work with a hospital institution, community-based individuals, perinatal quality collaboratives, and really start to think about one practice change that we can do to make a difference, and then how can we continue to build on that momentum. So that's something in our work that I'm really excited and looking forward to.
Thank you, Kim, for highlighting those community models, birth workers, and community-based health workers that are on the ground supporting parents navigate the systems and access to resources. It's really powerful to hear that those collaborative models already exist. They just sort of need to be expanded. Cassie, survivor-led advocacy efforts like SB 626 and the State Agency Roundtable are helping elevate these issues statewide. How are these efforts helping move the needle in California, and where do you see momentum building right now?
Thank you. And this has been such an amazing panel. I was hoping y'all would have a little AI battle here, because I know Elise is very concerned about AI replacing therapy, but I'm happy to hear we can all agree there's ways to leverage AI and technology and all the amazing solutions happening. So there's actually a lot giving me hope and inspiration right now in the perinatal mental health and justice movement. And I'm seeing momentum really across our interconnected strategies at CPWA of storytelling, systems change, and movement building. So first, survivor-led storytelling. I feel like the example of the motherboard is just the best, because when we first organized our first Pain to Power, we asked everyone in our registration to submit stories. We had 6 stories that were submitted, y'all. This Pain to Power convening, we had 70. Right? So give it up to yourselves, really, because give it up to you all, because that shows that we are destigmatizing, right? And more folks are feeling more comfortable breaking the silence, sharing your stories, and the more we can elevate that, both amongst ourselves, But to the media, to legislators, I can't tell you, I tell my story every single day. And I'll walk into a meeting with a legislator who's like, perinatal mental health, what? I tell my story, she's like, oh, I had that too. And I didn't even realize it because it was 20 years ago and we didn't talk about it back then, right? And that is happening in public spaces more and more. The motherboard came to Sacramento. Y'all told your stories 51 times to legislators. The next day on the Senate health floor, Senator Valladares shared her story. And then a dad next to her who was a senator, he said, you know, that happened to my wife too, right? So it's a ripple effect. When we had our state roundtable, Jennifer Siebel Newsom, I'd never heard her publicly say this before. She said, you know, I was on the phone with my mom last night talking about my mental health challenges. Governor Newsom looks over to her and says, I didn't know you went through that. Wow. That is us, okay? That is this movement creating that ripple effect, okay? That is how we move the needle. And, you know, in terms of policy and systems alignment, that's why SB 626 and the roundtable are so important, because it's convening folks across sectors, across systems, seeing ourselves in these stories. California's already got a B+ on the national level for perinatal mental health. It's actually the best grade in the country compared to all the states. So we are doing well, but there's so much room for improvement, clearly. And that's why we're advocating through our state agency roundtable for we're going to relaunch a California task force for maternal mental health that will lead to our hope is a comprehensive plan for perinatal mental health that y'all can be a part of, envisioning what's next and what's needed. And that's how we get to our Office of Perinatal Mental Health. And so that brings me to my third point around movement building. You know, real change in public health, it takes everyone here, providers, parents, birth workers, advocates, funders, policymakers, community organizations, partners, and fathers. And the way I see this movement, it's where breast cancer was 50 years ago. You know, 50 years ago, if a mom had a lump, she might not talk about it for fear or stigma, right? And we have seen so much change and awareness around that issue, where awareness shifted culture, culture shifted investment changed systems. It's the same with HIV/AIDS. So we know what works, we know what the solutions are. And not everyone has to run a statewide coalition or pass legislation. You know, sometimes movement building, it starts with telling your truth, like so many of you bravely told your truth today. It starts with checking on a parent, with changing one hospital practice, with funding community care, or helping one family feel less alone. And I recently heard Supervisor Holly Mitchell, she was asked, how are we going to meet this moment in these horrible times? And her question was, how big is your brave?
Nice.
And I think about, you know, we are the ones we've been waiting for, right? So that's what gives me hope, is that people across California are refusing to accept fragmentation and silence as inevitable anymore. Survivors are organizing, providers are speaking up, communities are leading. And across sectors, folks are recognizing that healing families is not someone else's responsibility. It belongs to all of us, and that's how systems actually change.
Thank you so much, Cassie, and thank you all for such a thoughtful, honest, and grounded conversation. As we close, I just want to reflect on a few key themes that emerged through today's discussion. First, storytelling is not separate from systems change. It helps drive it. The stories shared today are not just personal experiences, they are evidence, insight, and calls to action that help shape how we respond, advocate, and reimagine care. What I'm also hearing clearly is that families are not falling through the cracks by accident. The challenges discussed today reflect systemic issues that require systemic solutions, solutions grounded in accountability, investment, and collective action across sectors. At the same time, this conversation reminds us that while many of our systems remain fragmented, the solutions already exist, and many are already being modeled within our systems. Stronger systems require deeper coordination across community spaces, clinical care, public health, advocacy, and policy. Families should not have to navigate disconnected systems alone. Providers, community organizations, policymakers, advocates, and public health leaders all have a role to play in building coordinated systems of care that truly support families holistically. And finally, today reinforced that community voice and lived experience cannot simply be included as an afterthought. They must help drive the design of the systems we build moving forward. Because the people closest to the challenges are often closest to the solutions. I hope today's discussion challenges all of us, not only to reflect, but to move differently, collaborate more intentionally, and continue pushing forward towards a future where all families are treated with dignity, respect, safety, and care. Thank you again to our incredible panelists for your honesty, wisdom, and vulnerability. And thank you all for being a part of this important conversation and movement forward. Let's give it up for our panelists.